but I suppose there's no reason about the details. I'm in the red corner, but I can't see the blue man right there, so I'm happy to take some extra over. Having said that, ACUTE is now evidence-based for ADHF, acute decompensated long-term benefit. Now, I would say the evidence has been around for, I'm not sitting with I'm fixing it. Hitting this and hitting the spacebar until wait a minute. So, I would say that now, I would say the evidence has been there since 5 years. It's only that the guidelines came now, and that's why now. Now, we're dealing with a very sick patient. Yeah? The patient is in hospital, and hospital now stabilized, and now set for discharge, or in the month of discharge, and that had a previous hospitalization. And low on blood pressure, eGFR, elevated NT-pro-BNP has iron deficiency, so heavyweight brand comes in there, and intolerant to GDMT, I doubt very much. If nausea is the reason why he or she, whatever was the patient, is omitted the GDMT, and that's what put her at a very high risk and made her even sicker. And the controversial issue, NYHA Class 4, which might be construed to mean that army is out. I'll show you, yes, very difficult wicket to bat on, and I'll need some extra overs, typically doctored by the great Kamal. But this is like mundane stuff, right? It is routine for the so-called heart failure specialist. Why worry about this? The key moment here, it's actually an opportunity. Hospitalization is an opportunity, especially in the pre-discharge as well as the post-discharge phase. Because all novel heart failure, acute heart failure therapies till date have failed. And we got to look for evidence out here. And the evidence, why? Because early treatment initiation in hospital is associated with improved adherence, and this patient is a defaulter. Not only that, discontinuation or non-use of GDMT is going to, ADHF is associated with poor outcome. So having said that, look at evidence, and the evidence for the 4 fights today comes from Pioneer HF, which I am going to dwell on, the Victoria Verisigwat, FMHF with Brian Pinto, and MPELS with Josh Bhai. So having said that, Soloist WHF was in diabetics, as also it was in a dual pathway inhibition molecule, SGLT1 plus SGLT2, so that's not relevant. So add to that, not RCT, but open label evidence, not 1 but 2 trials with ARNI, I'll deal with transition as well. And for all these 4 molecules, this patient should be stabilized. And I presume right at the outset I told you she's stabilized, because there is got to be hemodynamic stability, not on inotropes, stability of key laboratory tests, mostly vital organs, especially kidney, that it is showing stable parameters, and that of intravenous diuretics and being transitioned to oral treatment. This is the 2 clear reasons why people don't give ARNI. But if you look at the Pioneer inclusion as well as exclusion criteria, this blood pressure and this eGFR is fine to go on to ARNI. Not only that, the low EF, regardless of ejection fraction, look at the distribution of ejection fraction in the paradigm HF, as low as 5% to 42%, and consistent effect. ARNI is effective across the range of ejection fractions, even less than 28, and you can see with the point estimate for every other endpoint, including CD test. So, if you fear ARNI initiation, which are a patient mar jayega, that is the importance of all this. So, Pioneer first, and among the key questions addressed, for people who fear initiating ARNI, how to titrate the dose is very much there given in the Pioneer HF. And for this particular patient, I would titrate given a blood pressure in the 100 range with, okay, so dose level 1, that is what 50 milligram BID is what we would start with. Having said that, the up titration to the fullest dose in this study done in 8 weeks time. And mind you, the comparator arm, unlike my fellow worthy opponent, is not a placebo. It is enalapril 10 milligram twice daily. And what did they see? The most important marker of prognosis, NT-pro-BNP. down by as early as the first week compared to enalapril and return to be down. NT-pro-BNP in our patient are high, they're going to come down with ARNI. Not only that, you look at the safety which we are worried about, worsening renal function, hyperkalemia, symptomatic hypertension, angioedema events, no significant difference between the two arms. So also, and of course an explanatory endpoint, 46% reduction in the serious event composite endpoint, the same kind of a effect that is showing in the impulse trial which Jayesh is going to talk about. 46% reduction, impressive, driven mainly by the fact that this patient is not going to get re-hospitalized. Not only that, look at the extension study. What is that? Yeah. So look at the extension study out here. Not only in the initial phase, when we went into an open label thing, the NT-pro-BNP came down. But if you got what is called randomized to the enalapril arm, you never do well. The curves never come together again. That is the importance of starting ARNI now in this patient, as what Jing Wilcox in our editorial has to write. The optimal time to start ARNI, not only ARNI, all GDMT is now, that is in hospital, so that you can monitor closely these patients. Because they are all sick patients, isn't it? And look at this open label trial. Why open label? Done earlier than Pioneer trial, because it was unethical then, because ARNI was approved. And how can you go beyond 12 weeks with giving enalapril to the patient? So therefore, but the randomization here in this trial is pre-discharge initiation versus post-discharge initiation, and looked at mainly safety and tolerability to go to the highest dose. And the highest dose achieved whether you did it pre-discharge or post-discharge in 50% of HFrEF patients, stabilized patients, within 10 weeks. That's why I'm trying to tell you, give up on homeopathy, start low, but up titrate to the fullest dose of ARNI. And no difference between pre-discharge and post-discharge initiation. Having said that, again the same events that we are worried about between pre-discharge and the post-discharge initiation, the same safety, well tolerated, and rates of adverse events or treatment discontinuations were comparable whether you did it pre-discharge or immediate post-discharge. Small wonder then that there is a consensus amongst those guidelines about using ARNI as a first-line therapy in hospitalized HFrEF patients. And this consensus is very much there, as you can see here. Now all the fantastic four need to be started immediately as early as possible. But there is some little problem with this American guideline. I don't know if you can see that. That red box that I'm showing you, somehow they kept class 4 patients out, whereas the Europeans included all patients, all class of patients. Maybe the Americans got influenced by the latest published LIFE trial. But mind you, LIFE trial was about advanced heart failure patients. And if you go to the, and even otherwise, if you look at my competitors today, all the 4 trials here shown here, NYHA Class 4 patients are up to 9% in Pioneer in both the arms, both the enalapril as well as this arm. Whereas in Victoria, blue corner management around just 1.4%, about similar as Paradigm HF, isn't it? So there are only 11% of the patients started in hospital initiation. Jayesh Bhai is rocking out there, 9.8%. So, but NYHA Class 4, mind you, is not the same as advanced HF. When we are dealing with advanced HF, what are we dealing with? Look at the life inclusion criteria for a little while. And NYHA Class 4 symptomatology defined as chronic dyspnea or fatigue in the previous 3 months, and patients who require chronic inotropic therapy. I'm sure this patient is outside for discharge and not that time to worry about Class 4 patients that the Americans talk about. Current inotropic therapy or use of inotropes in the past 6 months was there in a quarter of these patients in the advanced trial. And even if our patients were in advanced heart failure, still you got to start right at the top there, the Fantastic 4. Why? Because this Fantastic 4 will give you survival benefit. All these 4 molecules. SGLT2 inhibitors are included out here. There is nothing about beta blockers and MRA here. We are talking here about ARNI versus SGLT2 inhibitor. I have shown you not 1 but 2 trials of ARNI where in hospital initiation and big trials for that matter, transition going on, 1,000 patient, 19 countries trial, going on for a year, the trial. So there is no fear about ARNI. Please do not fear ARNI, is what is the message. SGLT2 inhibitor, MPELS trial, again, what kind of a thing have they used there? They used what is called a win ratio in statistics. To try, there is one problem with win ratio going by, is that the win ratio does not, you are not able to assess the power of this trial, right? So you use few patients, you do a quick trial, you use all comers and all, and get the benefit. Yes, SGLT2 inhibitors are great molecule, but not the same robust evidence like what we have for ARNI. Again, the American guidelines do not, they talk about cost effectiveness, probably it's not so relevant for us, it's only intermediate value for SGLT2 inhibitor. And the other two heavyweights from Mumbai, these are mere planks to the in-hospital therapies that we are talking about in such a sick patient. These are planks, and these planks come only after the pillars have been put, right? So what do these planks have as guideline recommendation? Because they are planks, very sick what? Blue corner man is 2B. You know what 2B means, right? And very sick what? May be considered for a combination of hospitalization and CV test. That's the primary endpoint, only reduced hospitalization. Mind you, NT-pro-BNPs are higher, and patient needs to be already on GDMT. That's what smartly he said apart from GDMT. I don't think very sick what is GDMT for this patient, and that highest quartile NT-pro-BNP, more than 5,000, is a relatively, this molecule is going to become ineffective. The message here is that once this patient goes into the truly advanced heart stage, none of us four guys are relevant, right? We will think cardiac transplant, etc. for this patient. And IV iron replacement, finally, I know Dr. Brian has been such a big fan of IV iron, and 4 or 5 trials happened, all for functional improvement, quality of life improvement, etc., etc. Finally, the HF trial is giving hospitalization benefits, but yet this is the final slide, yet the ACC-AHA says you use it only to improve the functional status and quality of life. Of course, that does matter. And finally, I would say that we have the most robust evidence, and the initial dose level for this patient will be 50 mg BID, and we need not fear because इसके आमने बाद में हमारी ठीक होने वाली. Thank you, sir.
Good afternoon. So basically, Dr. Kirkar had made my presentation easy. That the heart failure patient or this patient require definitely great attention, and he is a very high risk patient. So my contention today is adding vericiguat is a safe and effective strategy and choice in this patient who is hospitalized. So what are the consideration in this patient? Definitely he is a HFrEF patient who is hospitalized 3 months back, and he has a CKD non-compliant to the treatment. So what are the questions? So what is this? Is it acute heart failure or it is a different population? How can we reduce the risk of hospitalization as well as worsening heart failure? And how we address the renal dysfunction, and what about tolerability issues? So we all know patients with heart failure, once they get hospitalized, they have very high event of rehospitalization within the 30 days. So it is a very risky window period, and each hospitalization decreases the probability of survival. So when we speak of heart failure, this is what we see the risk of a heart failure. On the left side, what you can see is the risk stratification of ASCVD. Now when the event rate per year is 7%, we say this is a very high risk patient for ASCVD, give him statin, treat his coronary artery disease. But when we speak of heart failure, the low risk heart failure which comes to OPD has a 10% event rate in year, and 40% those who are treated with all 4 drugs. If you treat with all 4 drugs, so the event rate without drugs is 40%, and if you treat with all 4 pillars, you can reduce the event rate to 10%, and these are the OPD patients which comes to us, and the event rate is more higher than ASCVD. But moment they have worsening heart failure, which means they get IV diuretic, whether they are hospitalized or an emergency setting, the event rate goes back to 20 to 30%. So we are dealing with a very high risk situation here, and we need to give them best of the possible options. Now, what is the risk of cardiovascular? Once patients hospitalized, this is what we say is a vulnerable period. Immediately after an hospitalization, 1 to 2 months is a vulnerable period where there is again a risk for an hospitalization, and there is a evidence-based strategies. If you implement here, we can definitely reduce the rehospitalization. And these are the studies to show that you first 3 months and 3 to 6 months you have a very high event rate in these patients. So guideline recommend what you should do. You should optimize this therapy, follow up early appointment, and initiate multiple therapies in the course of disease. So you need to add all. So it is not the one drug or another drug. It is about a polypharmacy, different drugs with different multiple mechanisms, and that we have seen in all fields. Diabetes, you start one drug, another drug. Now we say start combination. Hypertension, 20 years back we came that it is a different mechanism of action. Lipid lowering, initially they used to say there is no evidence for isobutamide, but now we say if we want to get a target, we want to save patient, you can start immediately. So here what we is important in this patient is different multiple drugs, polypharmacy, and how we can reduce these events in these patients. So what is the guideline says? These are the ESC guideline that you need to start this oral medication before discharge, and Dr. Kelkar has already told you that this hospitalization is one of the opportunity where we can optimize the medical treatment, and these are the 4 drugs which are already established in guideline. Now when a patient gets hospital, it is not important what drug he get. He should get all the drugs, maybe in the lower dosage is a new concept. So these are conventional sequencing. You add one drug, another drug, third drug, fourth drug. But now the era is where we want rapid sequences as in other medical therapies. Here you add low doses of these drugs, initiate them, and then continue and titrate as tolerated. Now it's very important that patient should tolerate the medical therapy, and then you can up titrate. So a traditional sequencing may take 3 months, 6 months, but here it is one of the rapid sequences which is recommended. So there is no clinical trial till now to say that how you should titrate one first or another first, and those all are not truly evidence based. So this is one of a rapid guideline, rapid up titration which is done in a clinical trial where you have a high intensity care, where during hospitalization you start half optimal doses of 3 drugs. So definitely this is a whole trial where there is no ARNI, there is no SGLT2 inhibitor, there is no vericiguat, and these 3 drugs they are giving on before discharge half dose of all 3 drugs, spironolactone, ACE-ARB and beta blocker. You call first week. Now in Western world it's a big problem because once the patient goes, they call after 2 month, 1 month appointment. The intensives cardiologist will see, then another doctor will see, and they require good guideline. We are lucky that our patients are lucky because we see ourselves as a cardiologist, we only follow up and then we do titrate, and we are following this actually before this evidence came. In 6-8 years we are doing very rapid sequencing in all patients. We are starting 3 drugs on day 1, day 2 of a heart failure. But now Western world and guidelines require this clinical trial to say that this is the correct way to give medical therapy to these patients. So second visit at 2 weeks, you see they are doing well, creatinine is not going up, potassium is checked, NT-pro-BNP, and if this is a safety visit, and by 3rd week you are giving all full optimal doses, and this is based or inspired by cancer therapy. Now heart failure, you see event rate like is cancer, but it is treated as flu. But in cancer, if you detect cancer, the oncologist says come next week, I'll give you 4 drugs and we will see, monitor for fever, infection, we'll see whether you develop a side effect. So this is based on the concept that you add 4 drugs or add 3 drugs, step them up and then see if the patient tolerate or not. So what has been seen in this, what you call is a high intensity, there is a significant reduction in the event rate. You can see this Kaplan-Meier curve, and what happens is that the trial needs to be stopped prematurely. As the control group, it is not difficult to continue the clinical trial, and this is a recent publication. And what has been seen that rather than achieving full dose of 2 drugs, the simple one drug, if you achieve one drug complete 100% target dose, you use 2 drugs, you do better. For example, beta blocker and ACE-ARB or ARNI. If you do half of both, that is probably much better then full of only the one drug, and that is what is logical, and that is what we are practicing in diabetes, hypertension as well as lipid lowering, that multiple drugs. And this is a meta-analysis or statistical analysis. The more drug you add, more is the benefit. So you have a multi-drug approach, and it's very good that if you add ARNI early, then patient tolerance of aldosterone antagonist is much more. If patients get beta blocker better, as they improve, the first patient who was not tolerating ARNI after 2 to 3 weeks is going to tolerate. So the concept now is not the one medical or this medicine, it is the polydrug therapy. And what you see that when you add any of the four, you can see the event rates are going down. So in our patient, when there is a recent worsening, what is the clinical trial which Dr. Kerkar has told, and this is what is the the clinical trial will go Victoria, but if patient is already on 4 drugs, still there is a very high event rates. So quadruple 4, even if you give, the event rate is very high, and there is definitely need of a new therapy, and the drug which we are talking very sure that it's what we call is work with the NO pathway. NO pathway we know since now 30 years. We are using nitrates, sildenafil, phosphodiesterase inhibitor, VOC-GUAD, and this group of drug. But this drug, what does new drug which we are talking is only stimulating this old pathway. This old pathway is endothelial dysfunction and reduce nitrous oxide availability. The Verisocate is a direct stimulator of soluble guanylyl cyclase and increases the cyclic GMP. By its action, it reduces heart inflammation, fibrosis, blood vessel vasodilation, and improve the renal function. So Victoria trial with this drug includes symptomatic chronic heart failure patients with ejection fraction less than 45% on already on available standard drug. So you are already on standard drug, and then there is a worsening event. Now if there is a worsening event means now you have selected a population which is the event rate of almost 20 to 30% per annum. And if you see this, there are 67% population is one which is hospitalized within 3 months, 17% within 3 to 6 months. So these patients, there is no run-in period. When you use an ARNI paradigm heart failure, you have to see they are tolerating or not. There is a run-in period, and then you select a population. Here there is no run-in period, because one of the big advantage of this molecule is there is no or minimum hypotension. And what has it shown? It has shown definitely, as Dr. Kerkar has pointed out, that there is no mortality benefit, but there is a very significant reduction in the heart failure primary endpoint, which is heart failure hospitalization. But please understand, this is only 11 very sick population, and within 11 months you could prove. And if you see, analyze it, a number needed to treat is 24, which is almost equal to all other drugs. So all primary and secondary endpoint in this drug, definitely this drug is a comparison with placebo on the top of standard pharmacotherapy. When Victoria trial was done, there was no SGLT2 inhibitor. So what you could see that the target dose achieved with Verisocate is 90% as compared to placebo, hypotension, syncope as compared to placebo, and any major adverse event in this population occur. So there is no incremental, it is just like a placebo as far as side effects are concerned, but it is working well when you compare benefit. Now what is an advantage? No reduction, major reduction in a blood pressure. So when we put this data in a clinical context, what we see as compared to paradigm heart failure, DAPA-HF, and your Emperor reduced trial, here this trial has a high NT-pro-BNP. These are more sick patient, worsening heart failure, and 84% population is recent hospitalized, and so much more sicker population. And what you can see, the number needed to treat is almost equivalent to all pharmacotherapies. So number needed to treat is almost same. So now in our patient, which is having eGFR, the advantage of this drug would be no renal dysfunction. You do not monitor creatinine, potassium. So and this from the Victoria study, there are all 3 different GFR. The drug they didn't have any significant worsening of renal function. The renal creatinine, GFR as well as potassium remains within the range. So no monitoring. Usually what in clinical practice what we are doing, whenever I am up titrating beta blocker, ACE, ARB or ARNI, we have to call every week, check pulse, BPO, creatinine, Here we tell first strip of 14 tablets, second strip of 14 tablet, and third strip of 14 tablet, 2.5, 5 and 10 milligram every 2 weeks. So that is what we say is tolerability and compliance is much better. Though we say very good that we should take all drugs, but in real world only 1% population receives all three, and this is a CHAMP heart failure registry from USA. And those who have many patients, we say that they should take ARNI, they should take beta blocker, but under treatment is extremely common. And whether you are inpatient, whether they are outpatient, and we have to accept the fact that we will have to add more and more therapy, though maybe in little lower doses. So majority of patients, even they have a good blood pressure, what you see, that's an under treatment. Definitely there is a quality care issue, because we have fear, perceived fear, and Dr. Kerkar has already told, don't fear with ARNI, but the truth is reflected in the statistics. The fear is so big and that's not going to go away. So these patients are to be treated like a malignancy, where you have to use polydrug therapy. We have to treat them very aggressively and fast in that window period. And there is a good this is an opportunity to improve the quality of pharmacotherapy. Now, if you see the retrospective database in Canada and USA, almost 40% to 19% of population of acute heart failure, they are eligible according to Victoria criteria. They are a possible candidate to improve their trajectory. Whether you have outpatient worsening, whether you have prior heart failure hospitalization or current recent event, you change the trajectory by Victoria by adding Vericiguat. You can see this is the event rate. Once you add Vericiguat, this is outpatient worsening. Patient in your OPD increasing diuretic need. This is a hospitalized patient, and you can see you are reducing. Moment you add Vericiguat, you reduce the event rate. And so the stable heart failure or a low risk is a myth. An acute hospitalized patient, you have to go with an aggressive polydrug therapy. So potential risk of attempting GDMT is side effect and adverse effect, but definitely they are much less than any cancer chemotherapy. However, if you do not increase, their survival reduce, hospitalization, quality life of symptoms are reduced. So one of my colleagues asked me that should I add Vericiguat disease patient? So because there is no evidence. So adding a drug is not a very difficult thing, because in cardiology we do many things. We don't think much. As a lesion is there, we are stenting the lesion and we do. But this is a irreversible therapy. It's not like a nuclear bomb. The Russian president says I'll throw nuclear bomb, but he doesn't do it because it cannot be retrieved. A drug therapy you will always initiate. If there is a problem, you can always withdraw that. Thank you. So this patient should be given a Vericiguat. That's what is. Thank you.
We're talking about acute decompensated heart failure. Now, I always tell my residents, when you talk about this, remember the word CHAMP. CHAMP means C for coronary, H for hypertension, A for arrhythmias, M for mechanical, and P for pulmonary. This is not really my talk. This is to teach people that when your patient goes into acute decompensated heart failure, you need to think of something why he has decompensated. And that's the way we go for it. Now, when we talk about this being a robust evidence, the robustness is never there because there's no money in it. Remember that. When you compared acute coronary syndromes and aspirin reduced mortality by 20% when you gave it in the 80s when we tried that. And what does ARNI do? It does very great things, yes, but it reduces mortality by 20%. That's great, that's wonderful. But how much talk about it depends upon the amount of money that is put into that. And who writes guidelines? Guidelines are written by people who sit in a room and not by people who work in the clinical scenario. So guidelines should be followed. Now I'm going to quote you one thing over here. Renato Lopez came one day and put up a slide. Said, read it. I read it. He said, class 1A guidelines, only 8% of them have 2 randomized trials in them. Only 8%. So who quotes them as class 1A? They They are quoted as class 1A by people who sit in the guideline committee. This is very important to note. The second important thing to note is that they up titrate and down titrate depending upon what they want to do. And we have to look beyond them to really treat patients in manners that we want to do. Look at what India does. India does badly if the overall situation is there. But India does extremely well in cities where we give treatment beyond the guidelines because we treat our patient just as Praveen mentioned. I may start very squat in a patient. In this particular patient, 77-year-old patient, I may start very squat before the 4 pillars have been started because I may not be able to implement one of the 4 pillars. Okay. But let me tell you, I will be able to start IV carboxymaltose in this patient without a problem. It will not cause any problem at all. And look at what is happening over here and what we are talking about. Now, you can see that they are affected at a younger age and it affects the patient's quality of life and discharge. Now, really speaking, one of these very bright people or 10 of these very bright people must have sat down and told us about these pivotal issues. And what are the pivotal issues that they wanted to consider? Add and switch. And one chap whom I think in this particular whole space whom I respect is John Nachman. This guy gives you a little bit of insight because he's both a clinician as well as a guidelines man. And what he tells you is that if you insert all these therapies quickly, rapid sequencing, I'm not going to read all this stuff because this is for you all to read. I have to interpret it. If you use all this stuff quickly, and if you were to implement all this stuff quickly, you will increase the quantity and quality of your patient's life in heart failure by about 6.2 years. But that is wonderful because all of us used to say that heart failure with reduced ejection fraction, your patients are going to die, 50% of them are going to die in less than 5 years' time. Now there's a lot of comorbidities that we need to look with heart failure patients. All of you know this completely. But we're just not talking about heart failure. All your heart failure patients have some amount of renal dysfunction. Look at that lady. What was her eGFR? 32. You'd struggle with some of the GDMT therapies. The trials may say start it, but suppose your creatinine bumps up and your urine output goes down, then you're in trouble. But it may improve also. So each patient has to be looked at very carefully. But I can say that my IV carboxymaltose can be given irrespective of the trial. You understand? And it will improve the quality of the life of the patient significantly. You can see that the evidence changes from each part, the association with heart failure and diabetes. What about kidney disease? Extremely strong association. What is the clinical evidence for modulating comorbidity? Extremely strong. Anemia. In fact, I will tell you one thing. I do serum iron studies and ferritin of all my patients. And you are doing them wrong if you are not doing that because 75, I must be giving at least 6 to 8 iron therapies every week to patients. Because even those who have a 14-gram hemoglobin have low iron. And you know, you can give me a few extra minutes. You know, how much iron do you have in your body? You have only 5 grams as a male in your body, maximum of 5 grams in your body. And what does a female have? 3 grams, by and large. It's a very, very important nutrient. You cannot afford to do it. Do you know what is the kind of gain loss that happens in your body? 1 milligram per day. That's all. So this is an element that is not lost very easily, not gained very easily, and it needs to be protected, very heavily protected, and you cannot afford to make any mistakes on that. Why do Indians have a very low iron level? 2 reasons. One is their nutrition is poor, maybe vegetarianism and all that, but more importantly, they are big tea drinkers. Now tea chelates iron. Okay, coffee does not, and orange juice improves your iron absorption. So if you want to improve your iron absorption around meals, then you use orange juice or have coffee, not tea. Now if you want to have tea, don't have it with your meal. Have it 1 or 2 hours after your meal, 2 hours maybe. Now you can see that country-wise iron deficiency is significant in the Indians. Look at the Singaporean Indians, 82% iron deficiency. So many people with iron deficiency. And if you check ourselves over here, I'll tell you the females are actually 90% of them, irrespective of heart failure, iron deficient. And males are also significantly. I give my acute coronary syndrome, my angioplasty patients, it changes their quality of life so significantly that they continue to remain with you only. They don't go to any other doctor. Because they are so happy with you, they are able to walk much better, they are able to exercise much better. And who is talking about only the quantity of life? Do you want quantity of life on a bed? Or you want quality of life? You want quality of life and quantity. Quality of life is extremely important. And this is the role, and this you must understand. Hepcidin. What is hepcidin? Hepcidin is a protect. Arey awaaz mat kar. No awaaz. Hepcidin is a hormone that is used in the liver, that the liver uses so significantly that when you have an infection, you will reduce the absorption of the iron from your body to protect yourself. That means any infective process, hepcidin is produced, and hepcidin reduces the iron absorption at that time, and this becomes even so in chronic inflammatory states. So the importance of hepcidin is there to prevent infection, and unfortunately when you have a chronic inflammatory state like heart failure also, your absorption is markedly because of this protective hormone that you have, which is called as hepcidin. Now you can see that because of that, everywhere the iron is affected, but it is done so as a protective mechanism. Okay. So what are the causes of this? You can see that by causing iron deficiency, you have so many other risks that happen. A reduced quality of life, increased risk of death, reduced exercise capacity, and besides that, it's a GI blood loss, malabsorption, malnutrition that causes all of this. So when you can see that, you can clearly see that the prognostic consequences of iron deficiency in heart failure are very significant. And I just want to tell you a couple of things. One is, the IV iron therapy does not improve you because it improves your hemoglobin immediately. What it does is that it is the powerhouse. The number of ATP molecules that are produced in your cell markedly go up immediately, and that increases your well-being. That's why IV iron therapy improves you almost immediately. And the recommendation for testing, and this recommendation was there long time back. It's a class 1C recommendation that you check with a full, and you do the serum ferritin and the TSAT. And one more thing over here, which is not related to this, you also check thyroid at the time of heart failure. TSH should be checked. Now, two things. Always get the ferritin done. Always get the TSAT done. Because you can see, what does transferrin saturation tell you? It tells you basically the amount of available iron. Ferritin tells you the storehouse. So you come to know and when you see very high ferritin levels sometimes, don't get confused. It is because of inflammation. Suppose you see ferritin levels 1000. You see that in COVID. You see that in other inflamed status. So wait for the inflammation to settle, but TSAT will give you the clear dynamics. And very importantly to note, heart failure and iron deficiency symptoms are quite similar for similar patients. So this I'm not getting into. So you can see a great number of patients without anemia have iron deficiency, and this should be clearly noted. Iron deficiency remains an independent predictor of mortality in anemic and non-anemic patients. This has to be clearly understood and clearly, kind of matters. Now, iron matters for contractility. Remember that if you do not use iron, the contractility goes down by a significant amount, and therefore you will improve cell metabolism. You also improve all the cells in your body. It's also useful for your muscle cells. And clearly, intravenous iron is the way to go. None of the oral iron gets absorbed. It doesn't get tolerated. So don't try to give your patients oral iron. It makes no sense. The trials have shown that there have been no benefits with oral iron. The iron out study showed you that, and therefore oral supplementation does not help. I'm in the yellow corner because most of my recommendations, the guideline people have not sat over it adequately. Not because I'm in the yellow corner for my own self. If they had taken enough evidence-based stuff and they worked on it, they would have seen that the classes will improve with time. The level of evidence is A, but remember, when you say level of evidence is A, you have got adequate trials in place. Okay? And therefore, you must look beyond what you are looking. And please understand that your drip is so simple. Your carboxymol, I'm not going to talk about all sucrose and all those things because they're old. They're old fashioned. You need to use a single dose, 1 gram usually, and you can do it not even without a drip. You can do it in a straight injection over 10 to 15 minutes, and you have this ability to do it. It's a great advantage, a great ability to do it, and we do it very frequently. All these trials have been there, and I think Stephen Anker has been at the head and the bottom of most of these trials, has been extremely good, and as Praful mentioned at last, we have the AFFIRM trial, the AFFIRM HF trial. The evidence, I think you need many more patients to really give you the data to suggest that this will be good. But clearly the beneficial effects are there, and you can see that how to give it I'm not going to get into because most of you know. What I'll say is that you need to check it after 6 to 8 weeks again, and then look at it and decide whether you want to give another dose or not. From this trial you can see that the ratio would be great. So for this particular patient, in spite of all the other pillars that you have utilized, please utilize the 5th pillar as well. Your patient will fare better with that. And in conclusion, I would say that only 1 or 2 injections, don't have to call every day, will benefit your patient significantly. And this is the first study where the iron supplementation in stabilized patients with heart failure clearly showed benefit. And it's not expensive. It's not expensive to give because it's not lifelong therapy. It's to be given in 1 or 2 doses. Thank you very much for your attention.
Respected seniors and colleagues, very peculiar topic. 3-4 years ago, when marketing people told me about SGLT2 inhibitors, I was little apprehensive about glycosuric drug being helpful. And then over the past 3 years, mammoth data has come, and we are now using it as one of the main pillars of heart failure therapy. My talk will be addressed to acute heart failure. Dr. Kamal has teached me in a very peculiar situation. Always Bombay speakers are very, strong enough to impart a good, and in that event I am just a mellowed down speaker who is projecting myself from Ahmedabad and projecting to, Dr. Praful has been our teacher when we appeared for DM exams 25 years ago, and that's the thing that I have to match with those recommendations. And I'll just jump on to Dr. Praveen's 2 slides. One slide documented that Emperor trial gave number of needed to treat minimum as compared to other compared. That means that empagliflozin was significant enough. Number of patients to be treated for target was very minimal. And second slide he documented was about the first drug to be started in acute heart failure, the first drug we mentioned was SGLT2. No talk about acute heart failure can go down without telling you about precipitating factors. All of you know about that, and I'm not going to narrate all these things. We have to treat precipitating factors. Of course, Dr. Brian has narrated anemia as one of the cause, but apart from beyond anemia, he has documented a very nice presentation. SGLT2 inhibitors have been shown to be a wonderful drug for chronic heart failure irrespective of diabetes. They improve cardiovascular outcome, hospitalization rates, cardiovascular death, all-cause mortality. And this effect is beyond glucose lowering action. What we know about is the pleiotropic effect. This word came when ACE inhibitors were introduced into the market, and of course SGLT2 has also pleiotropic effect, the effect beyond glucose reduction. There are direct actions on the myocardium, there are direct actions on the renal vasculature, there are direct actions on the systemic vasculature, but in nutshell, it is very much useful in heart failure. How do we see the impact on renal vasculature? That it reduces the SGLT2 receptor expression, it inhibits the NHE3 expression, and that's how it reduces the sodium and water retention. Why we started using SGLT2 in heart failure? Because heart failure and diabetes, both of them have endothelial dysfunction, both of them have insulin resistance, and that's why we intended to use SGLT2. And when we started with SGLT2, diuretic effect, natriuresis, glycosuric effect were very nicely documented, but there are some other metabolic effects like increase in glucagon, increase in ketone bodies. Ketone bodies are energy source for myocardial cells. Now we concentrate ourselves to SGLT2 inhibitors, and here when the patient gets admitted with acute heart failure, our target is decongestion. And by decongestion, I mean to say that you need to wash out all the sodium and water which retained, and there are some trials which are already ongoing, dictate AHF and MPA response. I'll just narrate it. But how early we should start SGLT2 inhibitor? All of our concentration has gone into the most right panel, where soloist WHF, impulse trial, and the ongoing DAPA ACT HF TME68. Those three trials are to be talk of the time now. Impulse trial, Dr. Kelkar has already told that we have a very, it is fitting into all different scenarios. Chronic heart failure, but now we have the empagliflozin in acute heart failure. The inclusion criteria included patients with acute heart failure irrespective of ejection fraction or diabetes. That means preserved ejection fraction is also one of the subset which will be targeted. Systolic blood pressure has to be greater than 100 millimeter of mercury, and there are no symptoms of postural symptoms of hypotension. There should be no increase in intravenous diuretic in last 6 hours time. There should be no IV vasodilators, there should be no IV inotropics, and of course documented heart failure by BNP or NT-pro-BNP. And the impulse design has very categorically started empagliflozin very early in acute heart failure admission. 3 days from the admission, they randomize the patients and look at the clinical benefit. The death was reduced significantly. Empagliflozin had a 4.2% reduction total death as compared to placebo, and quality of life heart failure event, the new heart failure event was also significantly less. Look at these graphs where probability of event starts separating. The graph started separating somewhere near 5 to 7 days, and the reduction in event, first heart failure event, was quite significantly seen over 90 to 100 days of study. So the net effect is that empagliflozin versus placebo, the acute decompensated heart failure was associated with significant clinical benefit, and that clinical benefit started as early as 15 days and was maintained beyond 90 days. So it is with fewer death, improved quality of life, and greater reduction in body weight. Now, this is one ongoing trial, dictate AHF trial. Diuretic response was being evaluated. Here, the empagliflozin has to be given, dapagliflozin has to be given early along with IV diuretics. And secondary endpoint was whether the patient still worsens over a period of time, or 30 days hospital readmission, or change in NT-pro-BNP to the untoward incident. The inclusion criteria are more or less same. Heart failure admission in last 24 hours, hypervolumic decompensated heart failure, and of course this trial was to evaluate no diabetic patients. So type 1 diabetes is excluded. The results are supposed to be coming in next April to October. Then the trial which Dr. Kelkar told you about is soloist. This is sotagliflozin. This is something different than SGLT2 inhibitor. It's a combined SGLT1 and SGLT2 inhibitor. And here the inclusion criteria included the heart failure patients on IV diuretics, stabilized off oxygen, and transition to oral diuretics were maintained. BNP was high. Type 2 diabetes was included. And of course, stage D and stage heart failure was excluded. Randomization started somewhere in early phase, and look, you can see that soloist sotagliflozin very clearly documented the benefit towards reduction in CV death, heart failure hospitalization, and urgent heart failure. And look at the lower panel. Lower panel very clearly says that you have the benefit, significant benefit seen as early as 28 days. So apart from SGLT2 inhibitor, a combined SGLT1 and SGLT2 inhibitor will also come on the horizon for our armamentarium. So soloist trial has very clearly seen that sotagliflozin significantly reduces the composite endpoint of total CV death, hospitalization, urgent heart failure visits, and benefit was consistent among all patients whether they were started on sotagliflozin before or afterwards, and heart failure with reduced or preserved ejection fraction. DAPA ACT HF trial still ongoing. I have already told you this has randomization on day 0 of acute heart failure. Guidelines have already incorporated. This is European guideline, of course, for chronic heart failure, where they have written 1A for dapagliflozin and empagliflozin. Then I would just draw your attention to last June-July AHA journal, and this is the trial of MPEG-HF, where empagliflozin was used in the acute decompensated heart failure, and there you need to go for whether urine volume is increased or not. The randomization was within 12 hours of hospitalization. The color is different here. So we gave empagliflozin within 12 hours of hospitalization. And you can see the better urine volume. The urine volume generated was very significantly higher over a period of day 5. And I would draw your attention that my patient had nausea. Kamal has nicely written down, nausea was there. Nausea can be because of hyponatremia. And I'm not worried about hyponatremia in presence of SGLT2. If I go on increasing the dose of torsemide or dose of furosemide, then probably hyponatremia will be very, very sub. While SGLT2 inhibitor will increase my urine volume. At the same time, you don't worry about hyponatremia. NT-pro-BNP very significantly reduces over a period of 5 days, and diuretic efficacy was stabilized after 3 days. Look at the last lowermost point. That shows that urine volume start decreasing after 3 days. So initial 2 days you wanted a orthopnic class 4 patients getting totally dry, and that is very effectively done by empagliflozin. Quality of life scores have also been very nicely seen. Look at the weight reduction. Acute heart failure, we are worried about weight reduction. We ask our resident a daily weight chart has to be maintained, and you can see empagliflozin reduces the weight very fast. Day 30, excellent reduction. Similarly, eGFR, Dr. Kamal has already narrated. We are dealing with a lady with high serum creatinine and low eGFR. In that event, ARNI, if I am starting on the first day or second day, already a patient in heart failure, low cardiac output, 100 systolic blood pressure, and we are dealing with a modest increase, say 20% increase in serum creatinine level over a period of 7 days with ARNI. So why to worry about those increase in serum creatinine level? And that's why my first choice will be SGLT2 inhibitor rather than ARNI in acute decompensated heart failure. The quality of life scores are already good with empagliflozin in early heart failure, acute heart failure hospitalization. Now, this is an old data, little old data where analysis showed that if your patient has one index event of heart failure, the empagliflozin fares better. All 4 panels, the lower panel is without heart failure and the upper panel is with one index heart failure. And look at all 4 graphs show a separation of 2 lines just before probably 5 days or 10 days. And that's where we need to involve. So by ARNI, as a very emphatically told to you, ARNI can be a class 1 indication, can be a very peculiar drug, but in my case scenario with 100 systolic blood pressure with eGFR of less than 35, I would really not tempted to use ARNI first. My first therapy would be SGLT2 inhibitor. And of course, my documentation will be further emphatically told by the clinical trials by the end of 2023. Thank you.